And in that sense, I will formally welcome
Let me
everybody to
put
the
it on
meeting.
so you don't have to hear it.
As you may have heard, the meeting will be recorded
Sorry.
and there will be some additional information posted afterwards on the
Good evening.
website. We've got several presenters with us today. As Dudley has just said, there's a huge amount going on across social care. We keep putting stuff on the website. People tend to ring up and say, why are you putting all this stuff? How are we supposed to find time to absorb all this? I'm afraid that's the name of the game. And if you're not on the case with things like safeguarding, working with other bodies such as the NHS, you're not going to survive much longer. And on that happy note, we have posted an item about digital survey on the website. And I would urge you to look at it and to complete it because digitization is going to come, like it or not. If you don't take part in surveys and make your opinions known, then don't complain when you get something you don't like. If you're not clear about it, then do call us, or better still, call Dudley because he understands it. And also, one of the providers, Care Visions, has very generously said that if you've got queries, because they have gone through all the legal stuff around GDPR, etc., they will help you. Um, Obviously, they're looking to sell their product, but they will give you time for free, and it will give you a benchmark. And that there is or are other sources of help out there. So again, we can point you at those, but do please take note. Without further ado, I will pass on to Dudley for any points, and then we will move on to Clement. Thank you.
Thanks for that, Peter. Just on the point Peter was talking about technology and digitalization, I think probably a lot of you are probably hearing or overhearing AI. When you turn on even Zoom, there's AI probably looking at you. So I think we will do a session around AI this at some point this year. I'm very conscious that even though AI can be a tool and used in a good way, we also really want to think about how we're using it in the right way, because what we don't want is organizations to get caught out. There's elements around GDPR. We also know as well when people are trying to work out for tenders as well, there are now bots which look at whether you've used certain AI tools as well. So just be mindful. But also as well, I think the final thing for me on that point in regards to AI is if you are using AI as a source to be your carer, remember AI cannot care for you. And if you are relying on information you receive from AI and it goes wrong, CQC and your local authorities will not be completely happy. So stick to obviously what you know first. AI just enhances some of the things that you're doing. So just be mindful as totally relying on AI at the moment. I think it's a key factor. Outside of that, we know that it's warmer weather as well. So for those who obviously who have people you're looking out for, your workforce as well, think about water breaks, hydration of staff, especially those dom care staff going out in the field. Also your resident service users or people you care for as well. Just be mindful around that as well. So fans and various things like that, a key factor. I'm sure you can understand that. But also as well, we must also think about as well the period of the summer holidays coming up, and we know that people off school. So also think about your workforce and balancing your rotas and how it can make sense. It's not always the easiest of times for some of you, but also as well, it's also trying to also around retention of staff. Staff feel they're not able to actually spend time with their family in some shape or form, then they potentially may not be staying with you for a lot longer. So please bear all of these sorts of things in mind. On the short, on the other note, we've got the WhatsApp group and we have emails. So even though you will be maybe feel that you're on holiday, we'll be updating you with a lot of changes. September coming up will be a lot of things coming up, things around employment, but we also as well outside of this are looking to try and formalize LCAS as being, if not the main, a leading care association body for London, trying to speak with various parties so we have more say around how things can happen. And but let's not forget, the information from LCAS is good. We can give you as much information, but if you have any queries, information or knowledge that you know, please do share it with us as well, and we will either investigate or sort things out. You've got things like happening in local authority where people are owed a vast amount of money, and we're looking into things like that. We are running surveys. We work nationally with the Care Association Alliance, who also are an amalgamation of all the care associations across the country. So we are trying to keep you up to date with as many things as possible, but also works both ways as well. So on that note, rather than tune your ears off with all this piece of information, I will pass it on to Peter. And this session's around safeguarding. As I said, it's an important topic all round. And for those who've been through any safeguarding investigations, probably wouldn't want to relive it, but also it's important of how we can get in front of it, or be as mindful as how we deal with elements around safeguarding. So thank you very much. Peter, it's all yours.
Okay, and without further ado, Clement, the screen is yours, sir.
Thank you very much. Let me slides up and running. There we go. Hopefully you can see those slides okay.
Yep.
Hi everyone, I'm Clement Guerin. I'm Head of Adult Safeguarding and Quality Assurance in Croydon Council, Adult Social Care and Health. And it's to be with you. I'm a social worker by background, but I started off working in residential care. I'm one of those old school social workers who came up from the front line back in the day. I've been in adult safeguarding work now since about, I was trying to work it out, so it's quite shocking. I've been an adult safeguarding specialist since 2005, so I'm probably one of the longest people knocking around has been doing adult safeguarding work for that length of time. And try to live up to the challenge that we set. It says adult safeguarding update. I'm not going to tell you anything very new about adult safeguarding. I'm not really going to talk about it, hopefully, from the local authority perspective. When I was putting this together, I was thinking, what's actually useful for you guys to know? And there's some issues that have been knocking around for a while. And I'm framing it in around, do we have a problem with adult safeguarding? What's the point of doing adult safeguarding? And try to give some pointers in practice that come out from those issues. So is there a problem with adult safeguarding? I think there is. This kind of demonstrates it. This is data that's publicly available. It's from NHS England. They publish it in particular ways. They don't present it like this. I have to go into the spreadsheets and dig it out to show it to you like this. This is the number of adult safeguarding concerns adjusted for population across all local authorities in England. And you can see at one end, we've got over coming up 4,500 adult safeguarding concerns per 100,000. At the low end, you've got about 400, no, it's less than that. I've highlighted where Croydon falls on the list here, just for parochial interest, but can it be true that some local authority areas are 25 times more dangerous to live in than other areas for people with care and support needs? I suspect it isn't. There must be something else going on. And start putting those local authorities, bunching them into bioregions, you can see there's something happening here. Just bunching around the middle, but there's a real outlier at one end with a high level of adult safeguarding work. There's a real outlier at the other end, London. Comparatively, it might not feel like it to you guys, but actually has quite a low level of adult safeguarding work compared to the rest of the country. Is the North East that much more dangerous place to live than London? There's something different going on here, isn't there? And then, even if you do that across regions, marking a real variation in the level of adult safeguarding work across London. And you guys know this, lots of you work with multiple local authorities, you'll feel this. Something different is happening. So can it be that some places are 20 times more dangerous to live than others, or I'll be counting different things, differences in practice in different areas. I'll go with the easy answer. I think it is about differences in practice. And mostly, as local authorities, we'll talk about what goes on in our area, and we'll ignore the issue that we're all doing different things. But you guys know it, you feel it, you're day to day. And it has real world impact. Look at that data. How useful is that data? If we're all counting different things, can we actually be held to account by comparing area to area? You can't. This is just telling us nothing, this data. And it's not just about what are we counting, I think. That reflects that practice varies a lot from area to area. So what's the impact for you guys? You've got to work with very differently behaving local authorities from area to area. And what's the real world impact for people with care and support needs? If we've got such variations in practice, and this is work that's about keeping people safe, what's the implications for people's safety? Why is this happening? I've got a hunch. Having been knocking around for a while and worked in various different local authorities, I've got a hunch, and it's something to do with how the Care Act was implemented. Got published in October 2014, got implemented in 2015. 6 months to implement a massive piece of legislation and put everything together. If you think just in terms of adult safeguarding work, no secrets, the statutory guidance that preceded it, that was published in 1998 and implemented in 2000. I had an 18-month lead-in time for people to get their heads around it and get to what was going on. The Care Act, massive piece of legislation covering the whole of adult social care and a whole load of things for the NHS as well. Got implemented in 6 months. And I think there was an incentive, a narrative developed that this isn't anything new, it's just consolidating existing bits of legislation. There are a lot of it. That's true. The adult safeguarding element, that wasn't true. Adult safeguarding under no secrets is quite different to adult safeguarding works under the Care Act. And this idea that this is just consolidation, no major changes, hid things. For anyone who's around who was interested in these things at the time, you might remember there was a no secrets review that was published 5 years before the Care Act was done, and it led to these changes in the framework for adult safeguarding that are reflected in the Care Act. But rather than being a standalone bit of legislation, because the government knew the Care Act was coming down the train, they delayed implementing the no secrets review and just consolidated all into the Care Act. It's a bigger change was being made around adult safeguarding. So I think the impact of it means some areas picked up that there was a big difference in the way of working around adult safeguarding with the Care Act, and some areas, and it can be different. It's not at the level of areas. It could be individual practitioners in the same area. Some people are still working as if they were working to no secrets, the previous ways of working. And just to give you a flavour of what difference it makes, is bits of what no secrets said compared to what the Care Act said. No secrets modelled itself a little bit on the world of child protection. And if you've ever had any experience of that, you know there's a concept within child protection world of significant harm, and that's your threshold for doing child protection work, and it's the threshold for doing protection of vulnerable adults work, as it was called at the time, adult safeguarding work under no secrets. We would get involved in the local authorities' threshold for involvement when there was significant harm occurring. Care Act's really different on that. The review of no secrets was very critical of applying that, and so that's too high a threshold. What's important is risk. No harm needs to have occurred. The event doesn't need to have happened yet. Risk of abuse or neglect is enough to trigger adult safeguarding work under the Care Act. That's clearly a much lower threshold, and so you'd expect to see more adult safeguarding work as a consequence. So I think the areas that are seeing higher levels of activity are probably working at the point towards they're actually working to what the Care Act really says, and areas with lower levels of activity are probably working still towards what no secret said. And that's really problematic for you guys. there's two different ways of working around this work, and that's really challenging for you. What are you meant to do? The Local Government Association and the Association of Directors of Adult Social Services had to go at cracking this. They know there's a problem here, and they produced this guidance in 2020 about what is an adult safeguarding concern. How can we be more consistent in what is an adult safeguarding concern? And there's another piece of guidance that's set a bit beside it, published around about the same time, targeted towards local. So this is targeted towards people like yourselves who are making referrals of adult safeguarding concerns. And there was another piece of guidance targeted towards local authorities around making good decisions around which adult safeguarding concerns turn into adult safeguarding inquiries under Section 42 of the Care Act. But I think this was, there was a long gestation period to this. There was 2 or 3 years lead up before this got published, all the work that went into it. And it got launched in the middle of COVID. And messages in this and in the other equivalent bit of guidance have got lost. And so they haven't had the impact on driving that consistency that we would want to see. The key message in there for anyone who's thinking about making a referral of an adult safeguarding concern is you've got 3 criteria within Section 42(1) of the Care Act. Is it an adult with care and support needs? Are they experiencing or at risk of abuse or neglect? Are they unable to protect themselves from this abuse or neglect because of those care and support needs? It says that last one about the person being unable to protect themselves is really problematic if you're trying to make a referral of an adult safeguarding concern, because it's all contingent on information you don't know. Adult safeguarding work is pulling together information that might be in places and piecing the jigsaw together. So it says, as for you, as somebody thinking about making a referral of an adult safeguarding concern, go with the first 2 bits. Is this an adult with care and support needs? By definition, if you're working with them, they are. Are they experiencing or at risk of abuse and neglect? Risk of it's low threshold. Nothing needs to have happened yet. No harm needs to have occurred. It's a low threshold. If you've got reasonable cause to suspect in the language of the Care Act that those 2 things are true, make a referral, and then the local authority's job is to scrutinise that and think about the 3rd one. Are they unable to protect themselves? So that's what gets you into doing a piece of adult safeguarding work with an adult safeguarding inquiry. But why do we do it? What's the point of it? I suspect if I did a survey around everybody on this meeting now, you might think about pieces of adult safeguarding work that didn't feel that they had much of a point to them. And I think, again, that points to a problem with what the Care Act and the Care and Support Sector guidance where they've arrived at and the way they've landed. And it was for good intentions. The No Secrets review said that the way we were doing adult safeguarding work under No Secrets, and people who were in the field at the time might remember all those very prescriptive strategy meetings and case conferences and all these sorts of things. And some people could be at one and some people couldn't be at other. The No Secrets review said that's a useless way of working. It's working for anybody. It's too prescriptive. It's too clunky. So the Care Act and the Care and Support Sector swung the other way completely and said, not have any prescriptive process. We'll make it up case by case what you need to do, and it'll be putting the person at the heart of it and asking them about what outcomes they want. But the trouble with that is if you don't tell anybody what good practice looks like, you've just got to make it up case by case. You're never going to get good practice. You've cut your chances of something good happening. It's left people high and dry. This is the terrible secret around adult safeguarding work under the Care Act. My colleagues from our local authorities might shoot me for sharing this secret. The reality of it, and you know it, and you feel it day to day. We're winging it. But despite, I think the Care and Support Sector guidance is an awful document and terribly written and needs to be thrown out and started again. Every now and again, you find little nuggets in there of something useful. And this one is, I think, is one of the things that's really useful. And this is what I want to draw your attention to, because I think this is what can really help you guys. So it's paragraph 1494, if you want to go and look at it. And it says something fairly simple, fairly straightforward, but I think this is something that we can actually embrace, and it gives us a way forward. If we're going to do an adult safeguard inquiry, what are we trying to achieve? The objective of an inquiry into abuse and neglect after establish the facts, get the views and wishes of the adult with care and support needs, understand, assess the needs that they have for protection, support, and redress, and how we could meet them. Do something about it, protect them from the abuse and neglect in accordance with their wishes. Make decisions around any follow-up action that should be taken about people or organisations who may be responsible for abuse and neglect if any actually has occurred, because lots of adult safeguarding work hasn't been any abuse and neglect. That's a reasonable and useful thing to find out. And then be forward-looking. The establishing of facts bit is looking backwards. We always need to be forward-looking. How to help the person achieve resolution recovery. That's actually a pretty good menu of things to do. If you did those, we can all agree that that might be a solid, worthwhile thing to do. And there's another useful nugget buried within the care and support strategy guidance. It's a bit that's headed deal with adult safeguarding issues in regulated services. And the philosophy of that this projects is something that I've seen in practice we don't always live up to in local authorities. It says if there's a service where there's an adult safeguarding issue, the responsibility for dealing with that should be sitting with the service. And the employer or service provider, I think it'd be more useful if they said service provider rather than employer, because they are very stumbling blocks around if there's agency working or contracted out pieces of work. Service should investigate any concern unless there's a compelling reason for them not to do so. So that bit in the language of section 42 of the Care Act is, if those criteria met, then the local authorities must make or cause to be made in inquiries in order to decide what actions need to be taken. This is about causing to make. Cause to make. You guys, they're delivering the hands-on services. Something's happened within your ambit. You'll want to be responsible for it. My experience, and we should be putting that responsibility into the right place and not coming in with slides and boots at the local authority and waiting all over it. And that is actually there in statutory guidance. That's the law. That is what should be happening. And here's the trick to it. I really wish this paragraph was better, because what it says is, if those criteria are met, if we've got the reasonable cause to suspect an adult is with care and support needs experiencing or at risk of abuse and neglect, then that section 42 of the Care Act kicks in. There's a legal duty. There must be, it's non-negotiable, there must be an adult safeguard inquiry. It's really not prescriptive around what that inquiry can be. And what it describes here, I think, is the trick to it. You tell me that you've had this concern arise within your service and you've done these things about it, and that reassures me that no further action is required, then you telling me and me being satisfied that your response has been sufficient, that's the adult safeguard inquiry. We don't need to do anything different. We don't need to have a months-long process. You've done something, you've told me, I'll give you the thumbs up. So that in practice, this means if the criteria met, there must be an adult safeguard inquiry. You give me, ideally at the time you're referring the adult safeguarding concern, or at least in short period thereafter. You tell me what you've done, I say, that's great. What counts as sufficient though? That's the thing, and that's where I would point back to. If what you tell me means I can be sure that we've established the facts, we've got the person's views and wishes, we understand their need for protection, support, they're protected, we know what follow-up action is taken about any person or organisation responsible for any abuse or neglect if it has happened, and we're doing things to help the person achieve resolution recovery. If you tell me I can tick those things off, that's our quickest way out of dealing with an adult safeguarding issue. So what can I suggest around how you might be putting that into practice? One thing is, adult safeguarding work isn't special. Now, Dudley mentioned that feeling when the words adult safeguarding are mentioned and people tense up, possibly because they've had more experience with a local authority's response, or we've had been through experiences where awful things have happened to people. We know that happens. That's the point of adult safeguarding work, is to deal with that, but to deal with it well, not to add to the problems. And if you think about those things, establish facts, understand people's views and wishes, assessing their needs, putting things into action, holding people to account, supporting people for the future, stuff you do all day, every day. The skills, knowledge that you need to do your adult safeguarding work are not different from what you're doing all day, every day. And I worry sometimes that we mystifies adult safeguarding work. It's something that happens over there by people who've got some special knowledge. All of us every day are doing this stuff. And here's my idea for you. 3 T's to think about. You're training your staff. Describe what that adult safeguarding practice is, and then you've got a better chance of getting it. And I think much discussing about adult safeguarding are a bit rarefied and a bit done in the abstract. Think about those things that you want them to do: establishing facts, assessing people's needs, holding people to account. That's what your training should be focusing on: the practicalities of how do we do this, and how do we, when you're making an adult safeguarding referral, describe that to the local authority, and you've got a good result from them. One thing that I think we can step up on is, for both as local authorities and as people providing care services, is when we get involved in people's lives, we forget to tell them that we do adult safeguarding work sometimes. And it's late in the day, once you've got an incident in front of you, to start telling them, well, we do things when this happens. So be upfront with people who are using your services, their friends, family, your contractors and other services that you use. You do adult safeguarding work, and if these things arise, well, we're going to be doing something about it. It's easy to have that conversation in advance than when you're in the middle of the issue. And don't be afraid to take any initiative. It's sometimes, I think, because of that feeling, that anxiety about adult safeguarding work, there's a tendency to make an adult safeguarding referral with the bare minimum information and sit back and wait for the local authority to tell you what to do. I would urge you to be more proactive about it, including that referral. And we're worried about this, and we're taking it seriously. And here's the things that we've already done. And even if you align them to those objectives that are in 1494 to go towards, here's the facts that we've established. Here's the views and wishes that we found out from the person. Here's what we've done to protect them. Here's how we've held anyone who needs to be held accountable to do so. Here's what we're doing to make things better for the person in the future. If you demonstrate all that up front, or in short order shortly after, you're probably going to have an easy, more straightforward conversation with your local authority, because they can then just say, brilliant, you've done it, no further action required. We've satisfied everything that needs to happen. There we go. It's a quick whistle stop around some thorny issues in adult safeguarding. And I don't know if any questions arise from that. I'm very happy to take them, or on any other issues or questions you've got around the world of adult safeguarding.
Thanks very much, Clement. There's some really useful stuff in there. There were a couple of moments where the sound died for me. I don't know whether it did for other people, but if it did for other people and at any points that you missed, folks, then please do. You've got Clement in front of you, so please ask the questions. And I'm sure people ask Dudley and myself questions about safeguarding. We can't answer them because we're not experts. You've got somebody in front of you now who can answer those questions, so please do fire away.
And you can use the chat box if you need to ask a question specifically. I know every case is individual, and Clement can only speak on so much, but I think there's lots of scenarios when it comes to safeguarding. And I think he mentioned, or Clement, I know you mentioned various things from your point of view, of course, and how safeguarding is sort of viewed or could be sort of utilized. I mean, if people haven't got a question at hand, do you feel that there is a possibility that the way safeguarding is managed will change, or will it still stay the same, is a question I'll ask, because I know anyone who's been through a safeguarding investigation and successfully come through it at the end of it have always said that we didn't need to go through all of this if certain questions or things were dealt with at the beginning. So I'm not sure how we can, maybe the bureaucracy of the safeguarding process can be managed better, would be a question I would always sort of pose.
Yeah. Well, the obvious answer is we can always do better, and that's true of lots of things we do, particularly true about adult safeguarding work. I think it is clunky. It is sometimes done in ways that actually cause more trouble than it's worth, and let people off dealing with things. I'm optimistic in the medium to longer term about it, because the more that people see how good practice actually can be done and the benefits of it, and it's in everyone's interest. It's in our interest as local authorities, it's your interest in, as people working on the front line. It's in the interest of people who can support this to do this better. I think that knowledge is slowly spreading, and you guys can be drivers of it. You can say, this experience was good in this area, and so let's reflect that back, even if they're not asking for it in that area, and do it. And people, when they see good practice, anxious. That's what I can say. In the short run, particularly being London-centric about it, we've got the London multi-agency adult safeguarding policy and procedures, and they reflect a lot of the weaknesses that I've described that are in the Care Act, in the Care and Support Staff Guidance. There's a revision of them underway at the moment, and I've seen the latest draft, and it's underwhelming. So there was a really good opportunity there to do the sort of thing I'm talking about and describe good practice. So in Croydon, for instance, because we've seen that and we're not optimistic about it, what we're going to do is put in some additional guidance locally that describes that good practice. So we do that, and other areas, pick up that pattern and run with it. I think bit by bit we'll get there, and it will get better. Just in the short run, we're about to have a missed opportunity on the London-wide approach to it. So I'm sorry, I'm not a bearer of better news on that front. But we've all got a bit to play, and you guys are influential. So don't think that adult safeguarding work is just something that's done to you. That's the real message you want to get across today. Is you guys can drive it, and you can do the good practice and be the beacon of it, and that forces other people's hands. Yes,
I think
it gives the systems change.
Yeah, I think that's a very useful point, Clement, and it's one of the things that providers talk to us about is how can safeguarding vary from one local authority to another. Because as you said, many providers work across, 2, 3, 4, several boroughs, and yet get slightly different guidelines. And what we always urge the sensible ones to manage that sensibly is to take the common sense approach, because good safeguarding is good safeguarding.
Yeah. Absolutely, I'll commend that. And Peter, I think you've been very kind to say they slightly vary from area to area. I think we can see massive variations from area to area, but go with the good. Pick up what's good and run with it.
Yeah. I think one area that we have been asked questions, and I'm surprised no one's raised it this morning, is where local authorities are, and most of them are under financial pressure. So fees are low, and we're seeing packages handed back, and local authorities maybe not paying their bills. We've had examples where providers have referred their own local authority, if you like, to safeguarding around financial arrangements. And I'm never sure whether that's a good thing or a bad thing, or whether it actually works.
Whether it works, that's an interesting thing, because it's not going to fix the financial issue. But does it lead to an honest discussion about it? And where adult safeguarding work can help with that is in that first objective of an adult safeguarding inquiry, establish the facts. way that I would say that you go around doing that is it's got an analogy with the way the police work, what they call investigation mindedness in the police, and what we would call in the social care world healthy skepticism and professional curiosity. In the fact, let's say you've got something like a medication error that already happens. You know the fact is the thing has happened, but establishing the fact, you want to understand, well, what's the cause of that? And the way I describe to people doing adult safeguarding work is the first thing you've got to do in order to keep that open-mindedness and that investigation mindedness, that professional curiosity, start with at least 3 hypotheses around what might have happened. And for something like that, it could be this individual staff member has made an error, or it could be that there's something at the organisational level. The service hasn't put the right resources in the right place, and so there's no way that an individual staff member could deliver what was needed because they were under so much pressure. Or the third hypothesis is there's something wrong around the commissioning. The service hasn't been commissioned in the right way, and whoever's commissioned a service, and that could be us in the local authority, we haven't put in the right resources to deliver what we're asking on the contract. And in your piece of adult safeguarding work, you can address all of those issues and do that and reflect that back. If I'm on the receiving end of that as a local authority, and it's true, and there may be an element of truth to each of those parts, something might have gone wrong at the hands-on care. Something might have gone wrong around the organising, the care arrangements, and something might have gone wrong around the commissioning. Well, let's be honest about it, describe it. We can't. There'd be an injustice, I think, if we just blame the individual worker at the front line when there's these other elements in there as well. And we need to have those honest conversations. And you can do that in the context of adult safeguarding work. And you can do it without it being antagonistic and throwing mud. It can be about an open, honest, transparent conversation around it. There's opportunities, I think, in there, Peter, for you guys to drive that, and there's opportunities for us on the local authority side to be open and transparent and welcoming of those conversations and saying, how did we end up in this situation?
Exactly. I mean, I think it's important. I mean, another question that someone had asked me, it's your interaction with CQC, because obviously CQC, when it comes to elements around safeguarding, we know of inspections, we know how it gets raised. How does it work with your interactions with CQC and SAFE when it comes to safeguarding?
Sometimes it's great. Yeah, sometimes it's great, and other times it's really frustrating. The good stuff is when we've got a clear situation that's got some. There's a regulatory issue within there. There's a safe service issue in there, or whatever, and we're able to describe to them. We can use a piece of adult safeguarding work in order to tell the story to them around is an issue that they need to be paying attention to, and they take that up and do. Ideally, they'll do a piece of collaborative work with their service provider and do what they need to do to support them and raise up the standards around those issues. Ways of working with CQC, and sometimes it does come down to individual inspectors and our relationships with them. It can be where they're too standoffish and say, you do the work, you do your adult safeguarding work, and tell us about it at the end, and we may or may not get involved further down the line. And sometimes it feels like they're getting, then their involvement comes too late in the day to be effective. And they give very unclear messages, so you guys and we don't know what it is that they're looking for or what they're expecting. They're not even what it is they're looking for from us. And then the other end of the spectrum is we find sometimes CQC are putting unrealistic expectations on service providers around you might become aware of something that's happening in a person's private and family life, and you make a referral around that, and they take you saying to you, and what did you find out about what happens around that? And it's like, well, as a local authority, we can't share that necessarily with a social care service provider. That's an unrealistic expectation. We've dealt with it, and it's in a person's private and family life, but they don't want to share that information with a home care service or whoever. So managing those expectations, either in when it worked well, it really works well, but we've got too many experiences on them being over unrealistic expectations, doing too much or being too standoffish and not getting engaged, not getting the engagement that we would want to have from them.
Thank you very much. I'm not sure if there's anyone who wants to ask any questions. I did get a cheeky question in, but I'm not sure if I can ask that, if you're willing to answer it. I could ask. If no one's got any questions, I can pose that question. Someone asked me that question, if you don't mind. So if anyone wants to ask a question, you can do, or I will pose this question to Clement. Okay.
Go on, Dudley. You've got some proof now with your cheeky question.
Has Croydon Council been taken on a safeguarding claim themselves, and how do they handle that? And so that would be the question against Croydon in itself. So
yeah, well, there's an interesting thing in there. There's an issue about language within adult safeguarding work, and I really try and dissuade people. And I have a metaphorical swear box on my desk about the use of the word against in adult safeguarding. I really don't like it. Safeguarding work isn't against anybody. It's about the person with care support needs. So that's the first thing. So just the language. If I could wave a magic wand, that'd be one thing I would want to do. Change how we use language in adult safeguarding work sometimes. But do we do adult safeguarding work about ourselves? Yeah, we do. And it's tricky. In Croydon, all local authorities are set up this way, but in Croydon, we've got a dedicated adult safeguarding team who do the adult safeguarding inquiries. In other local authorities, that sometimes the team that hold the cases will do their own adult safeguarding inquiries. So, so I'm regularly having to manage my team doing adult safeguarding inquiries that are looking at work done by one of the other teams within our organisation, and we're quite proud that we do that and hold ourselves to account. I'm sure people from the outside will say we should do it more often and we could do it better, but it's not a zero amount of work we do. And again, it goes back to that. When we're doing a piece of adult safeguarding work, we'll do that thing around thinking through the hypothesis at the beginning. Is the problem in the world out there, or is the problem something that we've done, or more to the point, have failed to do? Is it organisation abuse or neglect on our part? And we do hold ourselves to account with that. And I think if you look at some of the Safeguarding Adults reviews that Croydon Safeguarding Adults Audit have published recently, and there was one that they've just published in the last few weeks, where there was a person that we were working with who was neglecting themselves. We were told quite a few years ago around a mental health diagnosis for that person, and we just lost information, and it didn't inform any of our assessments for that person, and we might have done things very differently if we were cognizant of this mental health diagnosis. And that's in that Safeguarding Adults review because we said so and put our hands up to it and held ourselves to account on it, and are doing things differently around that how to make sure that the information percolates down for our assessments. So we do it. We can do it better. We should be doing more of it, but we can do it, and we're unafraid to do it.
thank you for that very much for that, Clement. I was about to ask for that question: how many cases have you? How many on average? How many cases do Croydon have to deal with against them? But I will leave that right there. Peter, I'll leave it with you.
I think, but yes, take a step back, I think is the term, Dudley. I think thank you very much, Clement. There's a huge amount of information there, and it never does any harm to refresh people's take on safeguarding and to update them. And again, what we find is that it's one of those things in the background that does get ignored. It's taken as a standard, and unless people do regular internal audits of their organization, those standards will slip. And any problem that crops up in a business, be it financial, be it safeguarding, whatever, is an opportunity to take a view of your organization and how you can do it better and how to improve. And training is an area that we know is not that good in social care and could be done a lot better. And safeguarding is a particularly important part of that training process. But the information is there for people to take. There's a lot of detail in that presentation, which we will pass on. Thank you again. And if people have got queries, then do please ask. And if you want to ask them anonymously, ask Dudley or myself, and we'll pass them on. We'll get answers and we'll share them. On that happy note, we'll move on to Briony. And Briony, the floor is yours.
Thank you so much. Hope you can hear me all right, colleagues. So I am Briony Sloper, and I lead the health and care in the community programme for the London region. And I'm joined today by two of my fantastic colleagues, Pauline Fahey and Dr. Leanne Gross. I just wanted to talk a little bit first about the programme, the health and care in the community programme across London. And it was initially set up just at the beginning of COVID with a recognition that, rightly so, lots of support for intensive care units and emergency departments, etc. The London region, together with social care, were very keen to ensure there was the same kind of support, oversight, information sharing, updates for care providers and community providers. So those staff that were out visiting people in their own homes, care home residents and staff, and over that kind of initial 6 months and then subsequently, I think the relationships, the communication channels, the kind of understanding and sharing across the sectors was really brilliant, and it was a pleasure, if I can say that, to work so closely with colleagues. As kind of COVID settled, if that's the right word, the London region asked for the programme to continue. So we continue to have that interface and focus on partnerships with social care and health. So the programme I lead is now kind of 8 national programmes under one heading, really. And in summary, and I can share slides detailing all of these programmes with colleagues if it's helpful. So one of them is the Better Care Fund, which is an amazing programme I'm hoping people are aware of, which is an integrated funding pot, basically, that health and wellbeing boards in partnership with community primary care, health, social care, use to really support improvements in outcomes and for staff and residents. Also community services, so we look after waiting lists, community workforce, data, all sorts of different pathways across our community providers. And very importantly, 3 of the National Ageing Well programmes. So enhanced health and care homes, which Pauline will give a quick overview of, but also proactive care, which is the kind of flip side of enhanced health and care homes. Enhanced health and care homes is very much about improving care and outcomes and support for staff in residential care settings, and proactive care is very much about supporting the same aims and objectives for people living in their own homes. Very much about people living with frailty, early identification and wraparound care and support. Also intermediate care, so that's bedded care and home-based intermediate care, again, early identification and support. Also digital transformation for social care, so lots of work with AI. So I like the reference to AI earlier. Acoustic monitoring, remote monitoring, shared care records access, so that care home residents and staff looking after them, as well as home care providers, have got access to the full records, discharge summaries, etc. And also discharge, so making sure that patients move through hospital as quickly as possible, safely as possible, and get home to their own home as quickly as possible. And also urgent community response, so that's a 2-hour health and social care response to people in their own homes, care homes or residential homes in their own setting, to prevent unnecessary trips to the emergency department. So it's a kind of high level summary. What I would say is our whole programme is about admission avoidance where possible, but really providing care closer to home and making sure that health and social care partnerships are strong. We're working as a continuum where everything is joint. We've got social care colleagues, and part of every one of our programmes has got social care partners involved, co-designing and delivering, and that we also have voluntary sector health watch colleagues, etc., supporting us with that as well. So we very much look at variation. We use lots of data to look at potentially where there's variation. It was nice to hear in Clement talking about variation in terms of safeguarding processes. And in a previous life, when I worked at the London Ambulance Service, and I managed the safeguarding team at the London Ambulance Service, as the only pan-London provider, we had to deal with all of the different safeguarding teams and local authorities. And I hear what he said in terms of the variation. So we look at variation. We look at where there's really good practice and outcomes, and where there's less good practice and outcomes, and kind of learn from the best and support people where they may be struggling more. We run lots of networks, bringing people together, again, from cross-sector to share learning, hear about things that are going on, not just in London, but nationally and internationally. Do a lot of quality improvement programs, so tests of change in all of those different settings. And as I say, it's a totally integrated program. I'm very kind of proud to lead it. We work very closely with the London Ambulance Service, and Dr. Grace will talk about her role there in the service. But any of those areas that I've talked about, if the membership here would like a deep dive on any of those, a specific presentation on any of those areas, please just let me know. We are doing specific improvement work around falls, specific improvement work around catheter care, and kind of outcomes and pathways and differences, and really about frailty and people's journey through hospital and A&E. We know there's very long waits, and how we can avoid and do things different and better. So that's a high level summary, Peter. Hopefully that didn't take too long. And I say, we've got lots of slides and things to share, but I just wanted to hand over to Pauline Fahey, who is the Enhanced Health in Care Homes lead for London. And also we run a concurrent programme of Enhanced Health and Care in home care to make sure home care and care home staff and clients and residents have got equal kind of access to resources and support offers. So Pauline, I saw you on the call, so I'm going to hand over to you if that's all right.
Thanks, Briony. Yeah, so thanks everyone. Thanks for inviting us here today. So so within Briony's team, I'm supporting the care homes and home care support for systems to, as Briony mentioned, primarily to enhance people's health and well-being, whether they're in their place of residence, but also try to keep people at home and avoid unnecessary admissions. So one of the big focuses of work that we look at is the Enhanced Health and Care Home Framework, which Briony mentioned. It's a commissioned service held by the PCNs to deliver in conjunction with other health and social care partners. It's a directed enhanced service, so GPs have additional payment to support and deliver this. And again, it's about people keeping people as healthy as and well-being as possible within the care home framework. And there are 8 elements to this EHH framework. Medicine reviews, obviously it's sort of, stands to reason, reviewing medication regularly will help and improve the outcomes for patients. A focus on LD and autism, specifically with their additional needs. Hydration and nutrition, which spans from various areas of, whether people are have wounds, whether they have catheters, but if we can focus on hydration and nutrition, we can improve their people's outcomes. Falls prevention and management, health, mental health, obviously as people age, their mental health increases and complex needs. Early diagnosis of dementia and supporting that process, identification of deterioration, and palliative care. So they're the elements within the framework that we really look at, and we support our ICBs and our social care partners to support and deliver this as best as we can. And we look at a lot of data and the variation, and Briony mentioned about looking at where there are really good examples where PCNs are delivering all of those 8 elements to a really good standard, and whether there are some PCNs that for various reasons are struggling, and how do we share that. So we have a care provider oversight forum that we bring people together. Again, as Briony mentioned, we pull together people from various different sectors, from our social care partners, our health partners, our ICBs, our London ambulance teams, etc. And so we talk around, we use those forums to look at good practice, as Briony mentioned, and also identify where there are upcoming challenges, which there always are in this process. We also have a real focus on the delivery of the Universal Care Plan, which is fundamental for supporting people and their care, whether they're at home or in a care setting, and that specifically for care homes, that the access for that is increasing. It's a slow rollout, but it is ramping up, and that really improve how when a resident or a person is moving from one health setting to another, and ensuring that there is consistency of care across those forums. We also support the seasonal vaccination programs to support the delivery of that, and ensuring that the maximum delivery is delivered. And as Briony mentioned, we've got big focus of piece of work on catheters. Our London region decided that we would have a real focus on how do we support catheters out of hospital specifically, and improve the outcomes for people, whether they need a catheter, whether they don't need a catheter. If they do need a catheter, how can we support them better and reduce, again, those unnecessary admissions? So we are pulling together at the moment, we've got various lines of focus, and happy to share those. But one of the big areas that we are looking at is a London regional catheter passport. But as Briony mentioned, there's lots of work with our various partners, and the other the sort of digital element of access for care homes is also under Briony's remit, and the London Care Shared Record is being rolled out as we speak, and there's about 16% of the London care homes now have access to that, which then allows them access to the Universal Care Plan. So that rollout is happening. It's quite complex. There are only 2 providers in that digital space, so it is quite challenging, but we will get there. And as Briony mentioned, we look at the data. We work with our ICB colleagues and our social care colleagues to identify where there are challenges. We also have been working with Leanne at looking at a specific care home dashboard. And that would be really helpful, because the data that we look at is very high level and we can't really escalate that to care homes specifically. But if they're able to understand their own activity, their own London ambulance call outs, their conveyances, they might be able to do some reflective practice in that, and work to support those people better. So I don't know whether I've missed anything, Briony, that you probably want to highlight, but it's a big whistle-stop tour through the big care home piece. But again, as Briony mentioned, happy to share anything going forward if you want something a bit more specific.
Thank you, Pauline. And I would add, obviously we have our big London, the Care Providers Oversight Forum. I'm not sure we've got a representative from this forum on that group. So if anyone is interested, I'd be kind of delighted if anyone wanted to join that group. We go through our kind of dashboards, looking at lots of different data points for care homes. We look at new research and innovation. We have people come and share great projects and pieces of work. Pauline and I are off visiting several teams over the next few weeks, and I know Leanne will probably mention the care home she supports alongside her role at the London Ambulance Service. So just really happy to link in. I can see some questions coming in the chat, which we can obviously take at the end. But thank you, Pauline, that's great. Really appreciate it. And so there's so much work going on in this space. Very happy to come back at any time with those specifics. I understand that the forum, there's particular elements of concern that have been raised, not only about safeguarding, which Leanne will be talking about in a moment, but also about end-of-life care and how we are supporting staff and residents in terms of education and training for staff, access to specialist palliative care, but also, again, in terms of paramedics and communication and awareness of end-of-life care planning, etc. So really happy to do more focused discussion around that area if helpful. And there's some brilliant work at the London Ambulance Service have done with their Macmillan end-of-life care team and kind of end-of-life care champions at every station, etc. And the work they're doing. And Pauline and colleagues, we've done lots of work on standardised training as well, and access and availability for social care provider staff, including home care. Again, it's just equally important that we're accessing and enabling training opportunities for staff across the whole remit. So I'm going to hand over to Leanne. I also saw Leanne join, so fingers crossed she is on the call as well. Leanne, are you there?
Yeah, can you hear me?
Fantastic, I can hear you perfectly.
Right, thank you.
So I'll let you introduce yourself and all the different amazing roles that you hold.
Thank you, Briony. Thanks for inviting me to come. I've got quite a lot to share with you, and when you get bored of me and I run out of time, I'm happy to come back again. I'll just give you a bit of background. I am Leanne. I'm a GP in North London, where I live and work. And strangely, I found myself looking after a very large care home 3.5 years ago. Never worked in a care home setting before, didn't particularly have any experience in geriatrics, and I found myself actually finding my passion in life. And really enjoying medicine again by being in my care home. Full disclosure, I work in Hammerson House on Bishop's Avenue, which is a really interesting place to work because we have so many different patients or residents, including end-of-life care, nursing dementia, residential dementia. It's quite an interesting place. And alongside that, and that learning curve that I'm currently on, I am Assistant Medical Director at London Ambulance Service. And I've been working with London Ambulance Service for a number of years. And I've kind of found myself in a role where I've been pulling all the bits of my portfolio together, which has been a really amazing experience, and being able to use my experience as a care home doctor to influence policy and procedure at London Ambulance. And in the past, I worked as a palliative care doctor. So finally, at this ripe old age, I've been able to use all my bits of experience and hopefully put it to some good use. About 18 months ago, I realised that London Ambulance gets a very large volume of call-outs to care homes over the course of a year. And actually, were we doing anything to address that? Were there any links within London Ambulance Service for care homes? And I think the answer was probably no. It wasn't particularly high up the agenda of an organisation that knew that care homes was a big part of its activity, but it wasn't necessarily on anyone's radar. So because I'm obviously obsessed with care homes currently, I found a few like-minded people within the organisation, and we self-established a care home group for London Ambulance Service. And I self-appointed myself as the Trust Care Home Clinical Lead. And we've just been plodding away over the last 18 months to try and make change. Obviously, London Ambulance is a pan-London trust, and there's currently 2 of us leading on care homes amongst a whole big other portfolio that we look after pan-London, but we're trying our best. Last year, we put together some priorities for our little team, and I'll just outline briefly what those priorities are. Number 1, as Briony mentioned, we were looking at data, and anyone that's seen the LAS care home conveyance data, well, it makes my head spin, and I'm sure it makes most people's head spin. Whether you get the data or you don't get the data, there's a lot of people that don't even receive it. Whether you can understand what it means, I definitely couldn't, and I've spent many hours trying to get my head around it. So we are using some of our BI team to try and make this data helpful and meaningful to care homes on an individual care home basis. And for quite a few months now, we are trying to put together a data dashboard. Unfortunately, because of other conflicting priorities, it's got moved a bit sideways, but it's absolutely at the top of our priority. And what we would like care homes to be able to do is to look at, be able to benchmark themselves according to other care homes of similar cohorts of residents, similar number of residents. Currently, it doesn't actually look at bed base. It doesn't look at whether you're a nursing home, a learning difficulty facility. There's none of not being able to compare like for like, which I think is causing a lot of concern. We need to be able to look at how many ambulance call outs there are, who's calling the ambulance, is it a healthcare professional, is it a carer, is it in the out of hours period, is it in the in hours period, and what is the result of those ambulance call outs? Are the ambulances conveying the residents to hospital? Are they keeping them in the care home? So there's lots of bits that on an individual care home basis or even on an ICB basis that we can use to change and inform practice. So that's number 1. Number 2, and I know it's been raised before I joined, is about the safeguarding issues. But for some reassurance, and safeguarding is my colleague Jodie's little pet passion. She's on holiday, but she sent me a little email summary, and I know there's a lot of mistrust between each other about safeguarding, in that my LAS colleagues are raising safeguarding concerns from care homes without having a face-to-face discussion with the care home prior to raising that concern, which I understand is causing an obvious breakdown in working relationships, which we can't have. Jodie has sent me some figures, which I thought was reassuring. For Southeast London, in a 6-month period, 3,474 call-outs to care homes and only 52 safeguard alerts raised, which is less than 2%. So I don't think we are raising lots and lots of safeguarding alerts. It's just the way in that we're doing it is possibly not the optimal. We recently moved to a digital platform for raising safeguard alerts, on which there was a tick box that actually said, I have discussed this with the care home. But I think what we found is this is not working in the way that we would like it to be. And I think that LAS clinicians are not necessarily aware of the impact of them raising a safeguarding, and they're also not necessarily aware of how care homes work, what's the reality, what's pie in the sky thinking. And I think that, and what's normal for an aging population in a care home and what's not normal. So we're doing a whole bit of education to try and support clinicians in their gap of learning. I, for one, take quite a lot of LAS clinicians to come and shadow me in my care home. I've had loads and loads. We've got a program of education that we're focusing on new cohorts of clinicians, on our advanced clinicians that go out in cars and are targeted to care homes. So there's lots of education happening, but obviously we employ 4,500 people, and it will take time to trickle through, but it's definitely something that is on our radar. One of the probably the most important things, and I'm really proud that we achieved it, I'll be interested to know if this is actually filtered to you guys, is that we prepared and launched a care home guidance on behalf of London Ambulance Service last year, where we put, I can't actually share it in the chat, I've tried, but I'll send it round after. We put together a flowchart for care home staff about if a patient or a resident deteriorates and they feel that they should call 999, some guidance on what information is needed, what the alternatives are, and how to prepare the resident. And we launched that last year with a webinar, and I think about 150 care home staff and managers attended, and we got really, really good feedback. That is definitely something that I'd be very happy to repeat, and invite as many people as possible to come and learn about our guidance and make sure that it's disseminated. And the other thing we're doing is trying to work with Briony and her team and others about UCP plans. As a GP, every resident that comes into my care home gets an automatic UCP plan. Obviously, I know that that's not universal pan-London. So it's about us trying to communicate the importance of this to my GP colleagues in London and showing them how this can change the management of patients and just expressing the importance of it. We also act as a kind of bridge between secondary care and the ambulance service in terms of care homes. And we speak to a lot of secondary care clinicians when things have gone wrong, that UCP plans haven't been accessed by LAS, especially in the care home setting, and patients' wishes haven't been respected. And following on from that, we've picked up a theme about expected and unexpected deaths in care homes, and the disconnect about what I, as a GP, feel is an unexpected or expected death in a care home and what my LAS colleagues feel. And there seems to be an increasing report to the police and coroners for patients that I definitely would call it an expected death, and that's causing quite a lot of concern in the care home setting, even in my own care home. And we're really excited because we are going to be doing something about this, and in the next few weeks we're going to be changing our internal guidance to help support care homes in this regard. And I know I'm probably running out of time, so I'm just going to say that locally, I work in North Central, and I've used the fact that I work in a really large care home to try and pilot individual projects to see if they. So, a couple of things to highlight. We in North Central London, we have a system called Silver Triage, where a consultant geriatrician between 8 and 8 will answer the phone from LAS colleagues on scene with patients in care home settings or with a frailty score of above 7 in their own home, and offer really holistic senior clinical decision-making support with onward referral into UCR teams and other community-based services. And that's just for LAS on scene in North Central, but we have been doing a pilot from Hammerson House where the service has been offered to the care home GPs, where we can use the Silver Triage service to just sense check or refer to community services from our care home. And that is going really, really well on a very small level. The other thing we've been doing is we've been putting on webinars, face-to-face events in Hammerson House for LAS, and using it as just sort of a site to hold a lot of people. And the last one we did, I think Briony, you came to that one. It was end of life care in religious faith settings. So obviously my care home is an Orthodox Jewish care home, and we do a lot of end of life. So it was about bringing LAS clinicians to learn about how they can support residents at the end of their life in the care home setting according to their religious beliefs. And we had an imam, and we covered Islamic faith end of life perspective as well. And that was, we had hundreds of people. We had people like sitting on the floor, and that was really well received as well. I'm going to shut up now, but happy to share anything with you later. I'm very passionate about this. You can be in touch with me offline, and I'll put my email in the chat. Thank you for having me.
Well,
Thank you, Leanne. That's brilliant. And I hope that's given you an overview of so how important the social care sector is, and social care providers are in terms of the approach we're taking pan London, whether it's the London Ambulance Service, whether it's our regional programmes. And so we've covered lots and lots of different topics and areas, and can deep dive into any of those, but felt useful to give you a sense of the range of improvement work, support, comms, training, focus that we are bringing across these areas. So I'll stop talking as well, and hand back to yourself, Peter and Dudley. And please, say I've not had a chance to look into the chat because I've been so focused on my colleagues' fantastic discussions. So please chuck anything at the three of us that's in the chat, and we'll do our best to answer any questions. And if anything needs follow up, we can do that outside of the meeting.
Thank you so much.
Thank you very much. I think if you're going to work with a care home, you can't get much better than Nightingale Hammerson, Nuno Lopez and his team.
So can I ask a quick question, Peter, just very quickly. Leanne, do you do a parallel version in the South, your Clapham, Hammerson, Nightingale House?
No, I mean, obviously it's the one organization, but their doctor setup is their medical setup is very different. And because it's a different ICB, their services are different. So Nuno is my link across it all, and the staff from the South London Nightingale do come to join the training, but it's very, very separate in terms of medical care.
Yeah.
Mm-hmm. Well, you did raise a point just then, and I was going to raise the other question about different ICBs, because I think we deal with Pan London as many care providers across the board. And I was going to ask you, some of the work you're doing can be impacted on being different ICBs. So I guess the question, I'm not sure who'd be the best one to answer, it says, how does that impact on whether it's training or all the offerings that you're putting out, because different ICPs work slightly differently?
So I can pick up that. I think Dudley and Leanne and Pauline do come in, but that's why we have kind of pan-London networks. For instance, the guidance that Leanne and the team have done, a London ambulance perspective, that's been presented to that pan providers from ICB leads, care home providers, home care providers, academics, community. You know, we've presented, got feedback, iterated it, and comms goes out centrally. And as much as possible, where it makes sense, we would like things to be as standardised as possible in terms of not building in additional health inequalities or access inequalities. Getting your GP, getting education, having palliative care in reach, being able to access community services and district nursing. We want things to be as standardised as possible. In some places, some variation is important to have local approaches and local needs, because different populations and different types of care home as well. An older adult dementia home is very different to what a learning disability home or a mental health home might need. But it's making sure that where that variation is in place, it's warranted. It's not because services are not equally spread. So we meet regularly with ICB care home leads and regularly with local care home leads who are delivering care and support, as well as our provider networks as well. So, and London ADAS colleagues as well. So we try to do as much as we can consistently, great comms networks, share everything out, but recognising there's still some unwarranted variation out there, and we can see that when we look at data.
Can I just come in a second, Briony, and just to say, actually, one thing that I get quite passionate about is the variation in GP cover and primary care cover for care homes, and I can see that when I'm working in London Ambulance Control Room and receiving calls from care homes where they can't get hold of a GP hasn't visited. And I have raised this with my primary care lead at NHS England, Agatha Nortley-Mesher, and I've asked that we rediscuss about the offer that GP practices under the DES and make it more transparent and not just a number ticking exercise, because I don't think just ticking the box for medication review is actually what we're expecting. And if I see care homes as a really big part of the UEC whole system, and if we want to keep people in the most appropriate place for them and avoid the emergency department where it's not necessary, then we need to be able to support our residents, and it starts with primary care. So that's something that I'm taking up, which I think is very much an individual basis, which is even worse than an ICB basis.
Yes, and it's very difficult. The primary care data is unhelpful in terms of the contracting and reporting data you get about who's doing what where. So it tends to come out when you can see views or creation of universal care plans to help and support that residents' wishes. When you see deterioration happening that's not been picked up, which it would be, you would hope, with effective in-reach and weekly home rounds, etc., and medication reviews. So it's something we are equally passionate about, and as I think Leanne and Pauline know, but my parents ran a care home for 25 years, and I grew up and lived in a care home, and I'm equally very passionate about the care home sector and how staff are supported, and so we're all coming at it not biased, of course, but focused, very focused on outcomes and support.
I think some of the points that are raised to us, and we're certainly not going to sort them in one meeting or in short order, full stop. With the ICBs or the ICSs, there are some that communicate better with the social care sector, adult social care, than others. And some of them basically think that they don't need to talk to basically to put it in a nutshell, they don't need to talk directly to social care because they get the information from the local authority, and the local authority think they know all the answers. And sadly, if only that were true, because it isn't. And unfortunately, I mean, Nightingale Hampson is fantastic. We use their South London home for events, and other care home managers have come in there and gone, God, this is fantastic. And it's brilliant. And Nuno and his staff have been very generous with their time and everything else. But the bulk of social care is dom care, and the bulk of social care business-wise is the SME. And not to gloss this, many social care providers frankly aren't that good and need to improve. There are a lot of good ones, and I suspect that meetings like this we get the better providers. But one of the things that comes back to us frequently is when social care providers, and they're largely going to be SMEs, deal with divisions of the NHS, they are not treated as equals. They are treated as being less knowledgeable and not given a deal of respect. And that even applies. We've had some very forthright conversations with nurses in adult social care who have not felt they have been treated as knowledgeable equals with expertise by their nursing colleagues in the NHS. And, you know, falls was one area that's mentioned, and that has been where a competent, you know, well-regarded, well-run, etc., home has had a falls incident, and somebody from the NHS has come in and addressed them as basically the words that the nurse said to me was, "We were treated like 4-year-olds." And it was an isolated incident. Yes, these things are all serious. And homes are looking at acoustic monitoring. We do a bit with LCAS. And that's all great. But again, the smaller location is not going to be as switched on. If you like, the individual unit costs are more than in a big unit, and the access to expertise. And we've had one or two really fantastic examples of where the NHS has shared training, which their training is generally great, and they've made it available to social care staff. That's really worked well, but it's not consistent. And the training budget for the NHS is huge. And if a bit more of that was shared, I mean, we, as an association, we always work hard to try and push training, you know, through LDSS and working with training providers like, you know, Social Works, etc., who will use that funding. But getting some of the shared, when you mentioned COVID, when COVID was on, LCAS did some work with SLAM and people like that. And as soon as COVID finished, the funding was cut. Social care, off you go, get on with it. And the well-being of social care staff is actually as equally important to the maintenance of a quality provision of social care as the well-being and the health of the people that are being looked after. Because and we don't have the stats, but you talk to people who leave social care and you talk to companies about their sickness levels, and a lot of that is down to stress and well-being problems. And the sort of, we're not going to fix it today, but there's a huge amount that could be done there, which is not yet being done. And we see some great examples where some local authorities are doing really good jobs around how they support people. LD was mentioned. LD is a prime exit area for getting things right. And also it's such long-term care as well.
I agree, Peter. Listen, I know we're running short of time, but this is a great piece of information. One thing is, I believe we're going to be sharing the slides, so people do look out for that.
Yeah.
And I also feel as well, because as LCAS, people are very time poor, managers and so forth. So actually sharing the information with us, we'll try and disseminate it as best as possible in as much layman's, managers, social care terminology as best as possible, because a lot of the time NHS terminology hits them and they are not sure what's going on. So it would be good to be updated, and we'll try and break it down as much as possible. And I love things like the universal care plan, which I think some people are aware of. It depends on your local authority or ICB as well, how that's out. And I think one of the areas as well, which I think important for me, you mentioned around, there's also been that element around ambulance services coming into services and the whole safeguarding. And I know there's a bone of contention. So that training and awareness for staff, ambulance staff, understanding, asking the question rather than safeguarding and next minute, as it happens so often. So it'll be good to see or understand more around that training. And I think it would help for providers to obviously see that something's been done as well. So, and I think you also finally put a call out for your forum. So I'm not sure how, I know you've said potentially we can actually, people are invited to actually apply if they want to join. Very quickly, how often does that happen? And
bi-monthly.
Bi-monthly, okay. All right, because it would be good, maybe we can actually have someone there and actually they can share the information and we can...
Yeah, and it might be over winter we step it up to monthly. What often happens just as pressures grow and all sorts of different things obviously can start happening, so we flex it, but at the minute it's every other month that we review each time.
That sounds fantastic. Peter, I'm not sure if you want to add anything else to that.
I would. I see that John Buttle is in the audience. Hello, John. Talk to me, John.
Hello.
And hi, John. I just wondered if you could give a very quick any updated information on LDSS training funding.
Yeah, well, thankfully it's still there. That there's an awful lot to access. There's no specific safeguarding training funding, which is a little bit irritating. But safeguarding is included in virtually all of the training that's done. So things like management, things like the level 2 adult social care, things like the medication training that we do, dementia training, it's all integrated within that. But it is annoying that there is no specific funding available. To access this, people will need to have their ASC data set account up to date, and then it's just a little bit of to and from and hurdle jumping with the learning development support scheme.
Okay, thanks, John. We can't stress enough that training is every time we talk to CQC, etc., training is a key area, and do use the government's funding, because if you don't use it, they'll take it away, and then you'll complain that there isn't any money. Okay, you got to do ASC. It's not great, but it's not that bad, and you can get some very good training for the money that you get through LDSS, and that is certified training, which is good for your staff, good for you, and good for the people you look after.
I'll just add into that, Peter. I think the training as well does apply for your international recruits as well. So that's very helpful. And it's not just your basic training, it also applies to things such as leadership and other things as well, which are available as well, which are helpful.
Can you send us the link again, please?
We will do, which is available for providers and managers as well, who are trying to continue their continual professional development, which is important for yourselves to upskill, which is always great, looking for that. So Peter, I know you've got, or John Buttle, I think you can share the information in the chat in regards to that, and then that can be helpful. Maybe they can come through you, because some people need to be just helped along, which would be very helpful in regards to that. So thanks for that. So all information, any questions, do ask us if need be. we also understand as well that everyone is busy, and we are trying our best to run as much information as possible, and also as well bear in mind that we want people to be able to access various things as well. So please bear in mind that you can also access information from ourselves. These are contact information where possible, and that you can grab that and access our WhatsApp group, but also email us in regards to anything. And also there's the website as well, for where we will be able to share our slides and any other information as well. Peter, before we go, I think we've got a few meetings left for July, and then I think we break for August, but we will be updating you. We don't stop the actual information, which is still running, but we will be having a managers meeting also in July as well.
Yep, Dudley is correct. Thank you. I gather Briony's had to disappear. Thank you very much to all the presenters this morning. Very useful. We will share the slides. We will put the recording on the website. We will send emails, etc., around to tell you about that, and we'll add in the LDSS information as well. We have a meeting on July the 9th. We'll send the information out, the invitation out for that shortly, and that will focus on the changes to the employment bill and working with trade unions. So we'll have a employment lawyer there, we will have Unison there, and Dudley will also share some information and updates on recent developments across DEI. So we look forward to seeing you there. Thank you very much for coming this morning, and hope you have a good rest of the day and that you've all learned something. And do remember to do your CPD, claim it on your CPD. Many thanks. Best now.